Today, we're answering questions from the comment section on focal therapy. We're going to be covering, if you have a family history of prostate cancer, is focal therapy still an option? What about your Gleason score? Can higher Gleason scores get focal therapy? There's so much more. So we're going to be talking to Dr. Mark Schultz, who's a 30-year medical oncologist who focuses solely in prostate cancer, and he's going to be answering your questions. Reading the comment section, a very common question that we get is, if I get focal therapy, how am I sure that they'll get all of the cancer?
The process of doing focal therapy in our modern times is still an evolving technology. There's two things that have slowed down the process of adopting more widespread focal therapy. One are the technical challenges, and the other are the financial incentives for the industry to just keep doing it the way they've been doing it. Getting insurance coverage for off-the-books type treatments, the retraining that's necessary, all these things make it much more complex proposition to do focal therapy in a really big business where there's a lot of men kind of going down the conveyor belt, getting surgery, getting radiation. If you address the technical side of it, the issues have to do with the limitations of technology, and then they have to do with the biology of prostate cancer, because prostate cancer is so common. It is something that can happen on both sides of the prostate. People can have two so-called primary tumors. People think if there's something on the left and on the right, that maybe it's spread from the left to the right. But actually, because it's such a common cancer, the most common cancer in men can have two different tumors. People that are contemplating doing focal therapy have to take that into account, be very fastidious about ensuring that there's not something going on the other side of the prostate, or they're going to be dealing with this problem in the near future as the second tumor surfaces over time. The answer is that absolute confidence about the absence of cancer on the other side of the prostate is not always assured. There is advantages to focal therapy that justify the risks of either getting a new cancer there someday or missing a cancer that's already there. The things that we do to try and ensure that we're not missing a cancer on the other side are high-quality MRIs, PET scans, PSMA PET scans. Those two things have provided a lot of value in that department. People are still doing random biopsies. I'm not advocating random biopsies, but those also can sometimes elicit a tumor on the opposite side. So if someone's had a PSMA PET scan, a 3 Tesla multiparametric MRI at a center of excellence, and many men have had random biopsies as well, and none of them show any cancer on the other side of the prostate, the level of insurance is pretty high that the disease really is unilateral.
Before I get to my next question, I just wanted to remind you that this September we're having an in-person prostate cancer patients and caregivers conference. It's a great way to, meet up with the prostate cancer community, to get your questions answered by leading physicians and so much more. And you can learn more at pcri.org. Now, don't forget to click that subscribe button, because when you do this, it tells the YouTube algorithm that this video helped you, and it'll push our videos out to other people who have questions about prostate cancer. And if you would like to donate and join our cause, you can do so at pcri.org/donate. Now back to my conversation with Dr. Schultz on focal therapy. So one of the questions, this leads well into it, that a patient asked is they had a Gleason 8 on one side and a Gleason 6 on the other. And they were wondering, do we just leave the Gleason 6 and can you treat the Gleason 8 with focal therapy? Or is because there's presence of two tumors on both sides, and even though one is Gleason 6, do you still need to cut out the whole prostate or treat it with radiation?
Right, this is a situation that comes up frequently. The realization that Gleason 6 never metastasizes has slowly percolated into the mindset of the industry over the last 15 years, but it's still not complete. There's many people that think of Gleason 6 as a cancer and are disoriented by the thought of leaving something behind. The idea of watching Gleason 6 is well established across 20 years of research, and the upside of focal therapy, that of reducing the chance of becoming impotent or incontinent, is quite attractive and certainly might justify the risk of just watching a Gleason 3+3 on the other side. All this sort of risk management is a dialogue that's going on between the expert and the client as they look at the different factors, advantages and disadvantages of foregoing treatment of a component of the prostate gland and the attendant risks. People that are going to do this, for example, are going to need an MRI every year to scrutinize the untreated prostate, and if a new tumor does show up, they want to detect that at an early and curable stage. So people who have whole prostate treatment can usually just check their PSA every year. So there's a different level of surveillance that follows people who do focal therapy compared to people that do whole prostate treatment.
Getting into the details of PSA, with that being the case, like let's say that, they have had focal therapy, the prostate's still there. Does the PSA monitoring, is it like a range? Because you don't really have like a PSA nadir to work with. So if, the prostate's a certain size, is it between a range, or what type of noise will that PSA be making?
Yeah, you can still do what's called PSA density, which is if you're getting an MRI every year, as we advocate, they'll know how much prostate gland is left behind, and then you can divide that by 10, and that should be the average PSA of someone who doesn't have cancer. We typically don't wait around for the PSA to misbehave before we order MRIs, annual MRIs in people that have had focal therapy. I think it's been pretty clearly demonstrated that if you're trying to pick up prostate cancer at the earliest stage, you're going to do better with an MRI than you will with PSA. The only exception to that might be in men who have very low PSAs. So for screening purposes in men that have never had treatment, or for monitoring purposes in men that are being followed after focal therapy, there's a certain percentage of men that have extremely low PSA, say less than 0.5. Their prostates just don't make that much PSA. And you might argue in those individuals that you could lighten up on the prescription to get an MRI every year. But MRIs aren't that difficult. They're very accurate. And in general, they're going to provide an earlier horizon on finding problems if something is surfacing in the untreated prostate area.
So one of the questions I saw was that somebody was wondering if they can get focal therapy because they just have one tumor on the gland, but they wanted to do hormone therapy as well because they were thinking if there is cancer present, maybe it's already in my bloodstream and I just want to make sure we absolutely are getting everything, and it would give them some peace of mind.
Well, this is another logical question that comes up, because the idea of doing focal therapy in someone who has high-grade disease, if you think about it, is also feasible. Men that have high-grade or high risk, or let's say early metastasis to their pelvic lymph nodes, are going to need radiation to the pelvic lymph nodes. They're going to need 18 months of hormone therapy if they have proven lymph node disease. The hope of focal therapy is to preserve erectile function. And certainly men that get 18 months of hormone deprivation are going to be generally on a romantic holiday, in other words, a vacation from sexual activity for some time, but may aspire to recover their romantic life after the hormone therapy wears off. And the men that undergo focal therapy are less likely to become impotent. So I don't think that high-grade disease in and of itself precludes the possibility of focal therapy if the basic metrics, unilateral disease, careful scrutiny of the untreated side of the prostate to make sure there's no cancer there. I think it is feasible to still do focal therapy in people that have high-grade disease or getting other adjuvant treatment for more advanced disease in other parts of the body.
There's so many different types of focal therapy nowadays that are being marketed out there. Is there one that you've seen has had, a really good success rate and that has had low side effects?
Well, I think well-executed focal therapy of all means is certainly associated with less side effects. When I think of average 60-year-old man who's not using any Viagra and planning to have either surgery or radiation, the chances of very serious erectile dysfunction that doesn't respond to Cialis or Viagra are somewhere around 35-40% of those men. And our experience with focal therapy is that the risk of developing that degree of erectile dysfunction is less than 10%. The advantages, I think, are clear-cut. The selection of the different type of focal therapy is like higher math, trying to find a center of excellence that is really specialized in doing this sort of thing. This is not something you want a doctor just doing a one-off and on the weekend. It's a relatively complex process, especially assuring there's no disease on the other side. And then the doctor who's delivering the focal therapy has to envision in his mind the tumor. It has to be well visualized on the MRI to be able to do that. And then set a realistic margin around that, because we know that the tumor could be bigger than the picture that's in the MRI, without going so far that they end up causing unnecessary destructive treatment to the areas of the prostate that don't need treatment, and then increasing the chance of impotence because of their putting such a big margin around this tumor. Selection of what kind of treatment is really more dependent on finding a maven that's become very good at doing one kind of treatment. I will say that the easier cases are the men that have large prostates, because especially if you have a lateral lesion, we're not so much worried about sacrificing prostate tissue unless the prostate's so small that when you put a margin around the lesion, it ends up encompassing most of the prostate anyway. What have you accomplished? So good candidates for focal therapy are people that have lateral lesions that are in large prostates, so that even if you sacrifice a nice generous margin, you still left most of the prostate untreated.
So we've talked a lot about brachytherapy and specifically seeds on the channel, and that's caused people to ask, can you do seeds and do focal seeds to, a single tumor or maybe two on the prostate, because since it's so effective and the studies have worked so well?
Yes, I think it is feasible. You have to find doctors that are involved in doing that sort of thing. You can do it with radiation, beam radiation, proton therapy. It's feasible. Pretty much anything except for surgery is a possible opportunity for doing focal therapy. HIFU, electroporation, cryotherapy, laser treatments, all these things, when managed by experienced professionals, work well.
So you mentioned, the 10% risk of erectile dysfunction. Is there any other side effects that are associated with focal therapy that patients should know about?
I would say the answer to that is how close the lesion that is being targeted is to the urethra would be one thing, because the urethra is a sensitive structure that runs through the middle of the prostate. So that's why lateral lesions are set up more easily for focal therapy. It's not impossible to do focal therapy with lesions close to the urethra, but it becomes more challenging. And if the urethra is in the treatment area, then it can be damaged or injured, and people can have a lot of the similar side effects that they'll get with regular radiation, where the urethra gets some radiation almost routinely, which means urinary frequency, urgency, discomfort, getting up at night more frequently, all these symptoms from irritation of the urethra.
So another question is, if they had a tumor on one side and they had focal treatment, they're wondering, can they do focal treatment again on the other side should a tumor pop up?
Well, I think this is another reason to deal with a doctor who's experienced in doing focal therapy, because experienced doctors doing focal therapy are aware of the fact that prostate cancer is common and that new spots can show up in the untreated prostate. The good ones are thinking ahead to that day, that if that were to happen, I want to not only select my focal patients for someone for whom that would be feasible, but also treat them in a fashion that if I have to retreat the other side of the prostate, that I haven't muddied the water somehow by being lackadaisical in how I treated the initial lesion. But the answer is yes. I think knowledgeable, experienced doctors can come back and do focal treatment, and we've had patients who have developed recurrences in the untreated prostate and have done well with another round of focal treatment.
Can you do focal therapy on Gleason's, 8, 9s, and 10s? Is it more on 7s? Is there a certain Gleason score that you would say, no, we should not do focal therapy alone in this patient?
Well, people think of focal therapy as a lighter touch, and therefore perhaps it's only appropriate for intermediate grade tumors. That belief, I think, is partly based on everyone's in the industry who treats prostate cancer being concerned about creating the appearance of being unprofessional or pursuing outside standard of care treatments. And if something were to go wrong, that they would be put in a medical legal position defending them. You only did focal treatment on this Gleason 8 or 9 patient. Situation is also further complicated by these PET scans now that are giving us more confidence that these higher grade tumors haven't metastasized. The way this needs to be handled is sophisticated focal doctor that can explain all these ramifications, and sophisticated consumers, patients, who can calculate the risks, the upside and the downside. There's no doubt that standard treatment with more extensive heavy-handed therapy will improve cure rates to some degree. The question is whether they'll improve it to a large enough degree to justify the side effects. And I think that's an educational process for the patient primarily, but for the doctor to communicate these risks and help the patient make a decision in conjunction rather than just declaring this is the right treatment, this is the wrong treatment. That can be stated in extreme cases where people have, widespread metastatic disease or have totally harmless Gleason 6 disease. This is the right treatment, this is the right treatment. But in between, there's always trade-offs, and that is an educational process.
When we're talking to patients, we see the psychology of cancer, the big C word, and I've seen it in a lot of your talks. And even with Gleason 6, there's a lot of concern. There's just this word cancer that's been labeled. So a lot of patients have been asking, Is it possible that, you would ever say focal therapy is a good idea for Gleason 6 prostate cancer, even though it's not going to metastasize, just because they want to get the cancer out?
Well, in this business, you never say never. The idea of treating Gleason 6 with focal therapy, to me, is a little bit of upside down thinking. If you do random biopsies, you'll find Gleason 6 oftentimes here, there, and everywhere throughout the prostate. So it's kind of, where do you begin and where do you end? You could argue, well, some of these Gleason 6 tumors are visible on a scan, and let's at least get rid of the visible lesion. The idea of doing focal therapy for Gleason 6, for me, would be for the person who is so emotionally crippled by this whole process and outside the realm of ability to envision watching it and feel they just got to treat it. Certainly they would be better off with a focal treatment than they would with a whole prostate treatment in terms of preserving their quality of life. But it's not something that we would recommend from a medical point of view. And a lot of the people that are treated for anxiety and emotional reasons, and this comes up quite a bit in the industry because the industry gets paid to treat, so they're kind of prepared and willing to treat people, even though it might not be necessary, just for their psychological well-being. It behooves us practitioners, us experts, to explain to these patients in a convincing way why they don't need treatment, why it's safe. Sometimes the industry is failing in that department, and the fears that drive people towards treatment, and those that don't need treatment, is partly just a lack of articulation from the caregivers saying why you really don't need treatment.
This patient has a 3+4 lesion, and they canceled their surgery because they got scheduled for it very quickly, and now they're looking for alternative options. They're looking at focal therapy, and they want to know what the side effects are of focal laser ablation.
When you talk about the side effects of focal therapy, a good component of the side effects is just the day you go to the hospital and get treated. So you're getting stuff jammed in your body and you're put in tight machines, and there's a lot of triangulation and whatnot. If you think about it compared to some of the other standard treatments, radiation and surgery, that seems like a walk in the park, but that in many ways is one of the greatest inconveniences of focal therapy, is the day of treatment. It's some sort of a procedure. Sometimes they put you to sleep for it. Side effects from the procedure itself can range from almost nothing. If people are putting seeds into, they'll have some bruising on the skin where that was done. They may actually just emerge with no side effects whatsoever, up to, including some people, rarely, who will indeed develop impotence. Also, some of these patients will stop having fluid ejaculation. Prostate is a compilation of a bunch of little tubes that lead down to the urethra, and so if you go in and destroy a section of the prostate, it's possible that those passageways will be blocked, and men can end up with dry orgasms after treatment, which is considered routine with surgery and radiation, but it's a surprising side effect to people who are having focal therapy, thinking of this as a more minimalistic approach. It can happen. As we talked about before, symptoms related to touching the urethra with the treatment, soreness, urinary frequency, nocturia, side effects that may go for 2 to 4 to 6 to 8 weeks while the body heals from the treatment is the next most common problem.
Would you still suggest focal therapy for a patient who had a extensive family history of prostate cancer?
Well, it's interesting. In the prostate world, family history as a determinant of your future, say your dad or your brother had prostate cancer, doesn't anywhere near foretell the future as well as what we know about what you have, your Gleason score, your PSA, your biopsy findings. The only exception to that would be in men who have a dad or a brother who had prostate cancer, say, in their 50s, early 50s. There is a somewhat higher risk of siblings developing prostate cancer. But the idea of focal therapy, I think, is somewhat akin to that of active surveillance, and that once people have treatment, they're monitored extremely closely. Not everyone with a family history is going to get another prostate cancer, though they may be at somewhat higher risk. I think the technology that we have now in 2024 and going forward is plenty good to detect these new tumors, even though they might be high-grade ones in some cases, at an early enough stage to cure them. So I don't shy away from people that have had a family history. I am aware of the fact that people who have had a family history sometimes have been emotionally traumatized by losing someone from prostate cancer, and I caution people that have had a family history to really go slow when they're diagnosed with prostate cancer, because they frequently overreact until they really get oriented in the landscape of this world of prostate cancer. The assumption that their story will be very similar to what their dad went through or their brother went through is is just widespread and typically not very accurate. The most of the prostate cancers that happen in families are just happening because prostate cancer is common, not because you had a family member. So don't make the mistake of assuming that your prostate cancer story is going to be similar to that of your family member.
So you mentioned age. Can you expound on that a little more? Because I think a lot of men, especially in their 40s and 50s and being diagnosed in those younger times, they really want to make sure to preserve as much, sexuality and just not deal with as many side effects. But a lot of urologists and a lot of people have argued against doing focal therapy for those men because they are so young.
Well, I think there are two reasons that the industry argues against it. One is it competes with their own product that they're trying to sell. And two is lack of familiarity or lack of access to a known focal maven expert who can be trusted with this process. I think that you need to be confident that you're not just doing focal therapy because that's the thing to do and not doing the background research and finding a center, and particularly even an individual that has dedicated their lives to doing focal therapy in prostate cancer. You don't want someone that's doing this part-time.
We talk about, the inconveniences of dealing, here in LA with traffic and having to have multiple radiation visits when patients are going. And that's patients are thinking, well, it's a life and death situation, but that's a huge inconvenience when you have to take off of work on top of dealing with treatments and doctors' appointments and insurance and money. So when it comes to focal therapy, are all of them a one-day procedure? Are there some where you have to do multiple days and it's a longer process, or is it pretty simply just done in one day?
Yeah, if you're going to generalize, it's a one-day procedure. There's some forms of seed radiation where they'll do a second implant a week later. But that's certainly the exception to the rule. These treatments that are being administered, cryotherapy, HIFU, are extremely powerful, and they destroy not only the tumor, but the prostate in that region with a surrounding margin. So you could argue that is one of the conveniences or the upsides of focal therapy is relative to some of the other treatment. The recovery is quicker, and the delivery of the treatment in a single day is attractive.
Thank you so much to everyone who left questions and comments in our previous videos and on our posts. It's because of those questions that we were able to develop this content today and create a video. So if you have more questions and more comments, please leave them in the comment section below this video. And if this video was helpful for you, go ahead and give us a thumbs up because it lets us know that you appreciated the content and we can move forward because we really want to keep our ear close to the ground and make sure that we're answering your questions as we create these videos. Now, Dr. Schulz mentioned finding a prostate cancer maven, somebody who's really good at that particular type of treatment. One of the things I notice is when I even, Google prostate cancer and I'm looking at treatments, I start to get these ads and you get marketing and advertising for, all sorts of prostate cancer treatments and supplements and all sorts of things. And it can be really overwhelming. A lot of information can be a good thing and a bad thing, but finding out who is the maven, what type of treatment I want, and what my particular type of prostate cancer case is really important. You want to know your own case so that you can advocate for yourself. And if you're told no or yes about something, you can put it in the context of your particular case. And you can ask questions of why is this not an option or why is this an option? And all of this will give you more confidence as you move forward deciding upon a treatment. Now, a great way to find a prostate cancer expert, if there's somebody that you're thinking about being treated by, call their office and ask them, how many of these procedures have you done? What were the outcomes of the patients who were treated by this physician? And is there a patient I can talk to who has had this treatment and I can just hear it from themselves? And if that's not an option, maybe they don't have a patient available that you can talk to, a great way is to go into a support group forum, either by in person or a forum or on the phone, and ask them and say, hey, has anybody been treated by this physician or has anyone had this treatment? Overall, this helps you develop your questions and get your research, and it's just a really great way to connect with other prostate cancer patients who may have been treated by the very thing that you're looking at. And these are great resources for patients. So we're going to leave them and leave the links to these support groups in the comment section of this video because I want you to reach out and I want you to get the help that you need. Now, another thing you can do is look at research papers. If there is a physician and you're wondering, I wonder how experienced they are, maybe they've written a research paper and maybe they're not the lead researcher, maybe they're the secondary. And wait, who is the lead researcher? And should I research him and see if I would like to be treated by him? Or maybe I can email their offices and see who they suggest I should be treated with by because they are doing this research. And you can even look on the bottom section of clinical trials and see what treatment centers there are and see maybe if there's one near you. I think overall, when it comes to getting prostate cancer treatment, one of the factors that is very inconvenient, but it's very important, is being willing to travel. I hear Dr. Scholes talk about this all the time. You don't just want to stick with someone local for the sake of getting the best treatment. You want to see in the world, in the US, who is doing the best treatment, and do I have the means and availability to travel to them? I know not everyone has that option, but if you do have that option, please take advantage of it. I think a lot of people try to stay local, and because of that, they're not really getting the best of the best. So travel may be an option for you, and it may be something you want to use. Now, if you need help developing your questions or advocating for yourself in those doctor's appointments, you want that shared decision-making experience where you're prioritizing your quality of life and you're thinking of things ahead of time, what side effects may happen and what will I do if those do happen. You want to make sure to have like a side effect mitigation plan. A great way to get help with that is to contact our helpline. These are prostate cancer patients who have been trained by our medical oncology team, and they can just, you can reach out to them, share your case, and they can give you information based off the questions you're asking, and we found this to be tremendously helpful. So please reach out to them if you need help. Now, you can find out more information about prostate cancer and any of the things that we talk about at our website at pcri.org, and please remember, most of all, you're not alone.